Welcome to the FMP Essentials Show. I am Dr. Yusuf Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials Show.
Disclaimer: the content of this podcast is for educational and entertainment purposes only and is not medical advice. Always consult a licensed healthcare provider before making changes to your health regimen. Views expressed by guests are their own and do not reflect those of the host or producers. No statements about supplements or products are evaluated by the FDA and are not intended to diagnose, treat, or prevent any disease. Listening does not establish a doctor-patient relationship. By continuing, you acknowledge and accept this disclaimer.
Now sit back, relax, and enjoy the show. Hello, everybody. Welcome to the FMP Essentials Show. I am your host, Dr. Yusuf Elyaman. My patients call me Dr. E, and we are here with a very special guest. We have Dr. Majd Isreb. He's a functional medicine doctor, an integrative medicine doctor, and he's a nephrologist. So, Dr. Isreb, welcome to the show.
Thank you, Dr. Yaman, and thank you for having me. I appreciate the opportunity, and my patient call me Dr. I.
Dr. I, so Dr. E and Dr. I, good. So here at FMP Essentials, we look at the functional medicine practitioner as a tree. We use the analogy of a tree, and the tree, a fruit-giving tree. And any tree needs a good trunk, and the trunk is really the strong foundation that supports it. And that trunk for us is knowledge. So getting into it, we will jump in and start the first part of our podcast here, which is the trunk or the foundation, the clinical deep dive. And today what we're talking about is a very important topic that I really wish more people were talking about, and that is chronic kidney disease. So, Dr. I, can you give us your 76-second bio?
Yeah, I'm graduated of Damascus University from Syria, and I did my fellowship and residency in Chicago with Northwestern University and Loyola University Medical Center. I also am functional medicine trained, certified by the Institute of Functional Medicine. And I've been in practice for more than 20 years. I wrote some books here and there, some poetry, and I also am working on an integrative nephrology textbook for Nature Springers, Springer Natures, and then hopefully that will come up later this year.
Nice. So you're not just left-brained; you got some right brain happening with the poetry.
Sometimes that happens. You get an idea, and you would like to, express it one way or another. So I come up with the idea and then follow up with the poem. So yeah.
So tell us about your poetry.
I write poetry in Arabic and in English, actually. So a lot of it was, I don't know, you're familiar with Syria and what was happening in the last 14 years, and there was the revolution. I write about my road in life, how I immigrated here. At some point in my life, I was, in nowhere between, Syria and the US. You end up in a invisible layer that between both countries, like you don't belong here, you don't belong there. Now is like I'm beyond that. But, and then the revolution happened and there was a lot of emotion that came with it. So I write about, how, things happen, and I write about the discrepancy or the difference between someone who's here and looking at something is happening there, and you can't really live the suffering that the people living every day from the comfort of your home or a gala, raising some funds for and then now finally we're a little bit where there's some freedom that the dictator is gone. So I write about that too, but we'll see how that evolves. Syria is now a fluid situation. Hopefully it will be for the best, but we'll see how it goes.
I hope so. So with FMP Essentials, who is FMP Essentials or the FMP Essentials show for? It's really for the functional medicine practitioner. But what we mean by the functional medicine practitioner is the physicians like you and me, and you're a nephrologist, I'm an internist, I'm also a pediatrician, I did med peds, but also the nurse practitioner, the PA, the naturopath, the chiropractor, the massage therapist, the health coach.
Mhm.
Everybody, functional medicine is just the lens at which we look at patients. It's our approach. And our approach is really looking at the root cause and trying to rebalance the system. The show is also for people that are interested in functional medicine, maybe practitioners of different fields that want to know what we're about. And I think now it's becoming very apparent that we're very evidence-based. We go to the research. We just have a bigger toolbox. I also would like this show to be something that inspires people, maybe people that are interested in a career. I hope that they'll watch this and take a look and say, whatever practitioner, whatever healthcare practitioner I want to be, if they want to do healthcare, that this will give them options. So that
Right,
being
right.
right. So that being said, let's go. Let's start inspiring. So those of you at home,
Yeah.
make sure that you are subscribing. Make sure you are sharing this with your family and friends. And if anybody says, "I don't know what I want to do with my life," show them this episode. So that being said, Dr. I, we you chose the topic chronic kidney disease. And chronic kidney disease, you are a kidney doctor, but you could have
Mhm.
chose other topics within the kidney realm. Why did you choose chronic kidney disease to be the first thing we talk about?
Well, I mean, it's really obvious. I mean, we are dealing with a chronic kidney disease epidemic right now, and nobody's talking about it. So if you look at the statistics, where there's a organization called the US RDS that publishes every year the number of dialysis patients and the number of kidney patients. And the latest that I have information from is from 2022. 1 in 10 or 1 in 9 uh, people in the United States and around the world have kidney disease. Some statistics says 1 in 7. And like people who are 65 years old or older, 34% of them have chronic kidney disease. So we're talking about a third of those people have chronic kidney disease. We are dealing with a true epidemic, and on top of it, we have the amount of money that we're spending on dialysis. We spent like $37 billion in 2022
Hmm.
on dialysis services alone. And on top of it, there was a $75 billion fee for service for CKD patients. So we're spending massive amount of money. And despite that, 1 in 9 people with kidney disease know that they have kidney disease. There is absolutely no awareness campaign. I mean, we're talking about statistics similar to breast cancer, right? So, and no awareness campaign. All the nephrology societies and association are not doing anything to raise awareness to the public. So that's why I'm passionate about this idea, because we really need to raise awareness about it. We need to change the trajectory. We cannot keep sitting silent here and seeing people just going on dialysis.
So 1 in 9 know they have kidney disease. And when I think about that, that's mind-boggling. That means that for every 9 people, that have kidney disease, 8 of them don't know they have kidney disease.
Exactly.
And
Exactly.
and and from a kidney disease, we're functional medicine, so we want to get to the root and we want to reverse disease if we can. We want to try, and with kidney disease, you got to get it early, don't you?
Right, right. And that is really the trick. And because, even like, I mean, we define kidney disease the way that kidney disease defined by the National Kidney Foundation is when the GFR, the glomerular filtration rate, is less than 60, or if you have functional or anatomical issues when the GFR is above 60. But if you think about the GFR, the normal GFR is about 120. So by the time someone is diagnosed with chronic kidney disease, they already lost 50% of their kidney function, right? So we're
Right.
way behind the curve already. So
So
early
so
detection is super important, because once you go down the rabbit of a hole of the stages of chronic kidney disease, you're already behind the curve.
yeah, so 60, that's that from 120 GFR to 60 and that's when they actually that's your stage 3A, right? And I know
Right,
most
right.
patients you talk to, they don't even know like they have 3A, 3B, and they don't even know they have it. But for those that don't know, can you tell us what a EGFR is?
So estimated GFR uses a formula that is complicated, came from research that is called the CKD EPI formula right now that we use without race anymore. And basically takes into consideration the serum creatinine, the gender, and the weight of the person. And it comes with an estimated number. So you plug in the number and you get a number, number of creatinine, you get what the estimated GFR is. So, like I said, anything above 60, the nephrologist doesn't even consider. And, you have stages of kidney disease, stage 5, stage 1 to 5, stage 1 when you have a GFR of more than 90, and stage 2 between 60 and 90, stage 3 between 30 and 60. And that's split, as you mentioned, to stage 3A and stage 3B. And stage 3A is between 45 and 60, stage 3B between 30 and 45. And then we have stage 4 when you're like way advanced now, and the kidney function is between 15 and 30. And stage 5 is when the kidney function is below 15%. This is like where I start talking about preparing for dialysis. Yeah, so, and there's the KDIGO. This is an international organization that came up with another uh, twist to it. So you can include the albuminuria level into the staging. So I'm sorry if I'm talking too fast and
No,
for
no,
your
no, you're good. I
audience,
want to
but
break it down a little bit. So you mentioned the calculation. So EGFR is glomerular filtration rate. So
Mhm.
so glomerular comes from the glomerulus, which is like the unit of the kidney, right? And that's the filtering
Right,
thing. So it's really
right,
looking at how well it can filter, right? That's and then
right.
creatinine, what does creatinine actually come from? Because you look in the
So
blood, most people will get a CMP or I'm sorry, a CMP or a BMP, they call it basic metabolic, complete metabolic,
mhm.
and they look at the BUN and the creatinine. But the creatinine, what are they actually looking at when they're seeing a creatinine in the blood?
So, a lot of people know the creatine because a lot of people take creatine supplement for their brain health and muscle. Uh, and creatine ends up being broken down, when you utilize it in the muscle, you produce creatinine. So
Okay.
it's a metabolite of creatine, and it's in this, circulating in the serum. The kidneys get rid of it. It's used as a marker of kidney function. It's not the perfect marker by any mean because there's a lot of factors that plays into it. We can go into the weeds here, but when we're talking about the glomerular filtration rate, we're
Yeah.
just estimating one function of the kidney, the glomerulus. So the nephron, which is the filtering unit of the kidney, has the glomerulus, and then you have the tubules,
Hmm.
and there's a whole other function of in the tubules where you balance all the electrolytes. We don't measure that by measuring the GFR. So
Hmm.
that is a big problem, right? And then creatinine also if you go into the weeds, it gets secreted by the tubules. So you don't always have a perfect GFR by measuring creatinine. It's probably the worst marker, but that's the cheapest we have. Cystatin C is the other um, market that we can use that can give us a better idea. I think the latest KDIGO guideline recommended that we use a combination of creatinine and cystatin C to have a GFR, better GFR assessment.
And look at it both. But I want to go back to the creatinine. So creatinine, you said, comes from the muscle. So from protein, protein will have creatine in it. Creatine is broken down to creatinine. Creatinine has to be filtered. So they say, all right, well, based on how high your creatinine level is in the blood, if it's high in the blood, that means it didn't filter through to the kidney. So that's why it's
Exactly.
accumulating. Now, is creatinine toxic in itself, or is it just happens to just a marker sitting around there?
It's just a marker sitting
Okay.
around as far as I know. I don't know if any data that says creatinine by itself is harmful. So,
And
but yeah,
we just
go
say,
ahead.
all right, if creatinine's not being filtered, then probably a whole bunch of other stuff is not being
not
filtered,
being filtered.
which hurts you,
Exactly.
which hurts you. So
Exactly.
then you mentioned, so because we're in the diagnosis here, they can check and I know bodybuilders, right, will sometimes have
Hmm.
a higher creatinine level. If people that are eating a lot of protein may
Right.
falsely,
Right.
people that
Yeah.
take creatine, they could have a false
Hmm.
high. And like you said,
Absolutely.
it's not really a perfect test. So now the cystatin, what is cystatin C in the first place? Because you said we could check this as well. What is it?
It's another marker that is circulating in the blood, and we can get it checked, separately, and you can get a GFR estimated based on that. So you get similar formula kind of thing with that. You give you the estimated GFR from cystatin C.
Hmm.
The difference, I think if you do what is called nomogram, you can see that maybe cystatin C has better correlation with the creatinine clearance or the isotope GFR, where you do nuclear medicine testing to know what the GFR is. But creatinine sometimes can be more accurate in some situations. Cystatin C can be more accurate in most situations. So, like for example, if someone has massive proteinuria, protein in urine, cystatin C might end up being not accurate for some reason or another. Well, in those cases, you have to, depend on the creatinine.
Okay, so because I've noticed this, I've noticed that people their EGFR is off, their glomerular filtration is off. With the looking at creatinine, so I'll check a cystatin C, and then when I look at the cystatin C, sometimes it's a lot lower. Um, and
Yeah,
the person and I was actually doubting the first one, the creatinine level as well.
yeah.
So you're saying that if one of the limiting factors is if the urine has a lot of protein in it, it could
Hmm.
have then it could affect the cystatin C level in the blood.
Right, right.
Okay, so what do you so I mean you mentioned it's in the guidelines. How good of a test do you think cystatin C is?
It's the probably better in general than creatinine. So I would use it specifically if I have doubt on like what's the patient creatinine, because I mean like it's more expensive obviously to
Yeah.
order it, and some insurance may still give you a hard time. But so it's more accurate in general, and like I said, the guidelines they recommend using both. But nephrologists right now still using creatinine, unfortunately.
And you mentioned though, you mentioned that the guidelines were saying that you look at both. So do you
Hmm.
just take both, add them up, divide them by two, and see what number?
Hmm. Yep. There's a
And then
formula actually for that. Yeah.
the way to really know what your EGFR is a nuclear study.
Nuclear study is probably the easiest to perform. Yeah, in a setting that that when you're in complete doubt and you want to really know, that something that's commercially available is the nuclear medicine. It's called isotope GFR order. And they can do that in any nuclear medicine facility.
So how often do you order those?
Uh, I've been practicing for 20 years. I think I did it twice.
Okay, good. At least you're giving them business.
Yeah.
I hope they're not depending on just you or me because I've never ordered.
No, no, I'm pretty sure they have other businesses, but
Okay, so
but I
so
mean, like these are when you have really serious doubt, then the numbers are not adding up. Like you have, like creatinine estimated GFR of like 60, for example, and the cystatin is like 25. I mean, like which one you're gonna believe? The
yeah.
easy way, you can do a 24-hour urine collection and do the creatinine clearance or cystatin clearance. But when
Okay.
you want to do a gold standard testing, I mean, nuclear medicine test is pretty
And
much
that's
the.
something you could get at a regular lab. So if you're like, listen, this guy's a bodybuilder, I don't believe this. This doesn't make sense.
Mhm.
You could
Right.
do a 24-hour urine collection and look at cystatin
Hmm.
C. Okay, and
Right.
then based on that, you can get a good number as well. And then
Right.
you mentioned the adding of albumin. So albumin is what the most common protein in the blood. It has multiple roles. It carries hormones. It helps with the charge. And albumin being in the urine. So checking albumin in the urine. Why would albumin start going in the urine in the first place?
So, I mean, we have the glomerulus have the filter, right? So you're going through, the blood's going through those tiny blood vessels, and it's filtering a large amount of blood, which form the filtrate. And one of the things that that filter does is it makes sure that the protein doesn't slip in, and the red blood cells, all the cells stays in the body, like the large molecules. And then you have the filtrate, you have some electrolytes that pass through, and then they go through the tubules, and the tubules will reabsorb some of those, reclaim the sodium that went through, and potassium, and so on. And you fine tune as you're going through the tubules to make sure you balance all the electrolytes and the blood pressure and the fluid and water. So all of that happens on the level of the tubules. So when any problem with that filter, the glomeruli, if you have leakiness through it for whatever reason, then you have protein seeping in, and albumin is the most common one to, as you mentioned, to slip through. And if you start seeing a little bit more albumin in urine, then that's kind of one of the earliest signs of kidney disease that we have right now. So you can have the normal is supposed to be normal, less than 30 milligram per gram, and then you go from 30 to 300, and then above 300 is considered the highest. But we can see what we call nephrotic range proteinuria when albumin in the urine is 2,000 to 2,200 milligram per gram, and that become like really big problem. So when you talk about the definition of CKD, so we talked about the stages. Then there's the staging depending on the albuminuria or the albumin in the urine. So anything below 30 is considered A1, 30 to 300 is A2, and above 300 is A3.
Okay.
So kind of give you also prognosticative ideas. So the higher the protein, the more advanced kidney disease, the faster the progression of kidney disease based on the research.
And A1 is normal?
I mean, normal, but I mean, I don't really know what is normal. I think we shouldn't have any significant protein in the urine, to be honest with you. So 30 is considered normal, below 30 is considered normal, but I think even below 15 should be, or even undetectable.
So sometimes you do the test and you see it undetectable.
I do, yeah.
Okay. So back to that, and I think that's where in functional medicine we know it's a spectrum, and
Mm-hmm.
it's not till it starts causing specific endpoint or diseases that we would actually call it or say that it's abnormal. But kind of like insulin, if you look at with insulin or like A1C hemoglobin for sugar, it's not diabetic until it's 6.5, the
Mm-hmm.
A1C, but then 5.7 is hyperglycemia, and then maybe 5.6 and 5.5 is also a little on the higher side. So we kind of
Right,
want to catch it
exactly.
early. So for you want to see that negative. And just for the audience, like a urine dipstick shows protein, but microalbumin, a urine microalbumin, which could be a dipstick, is going to look for it's going to be more sensitive to pick it up. At what
Yeah.
level of albumin will the protein show up on your dipstick?
We're talking about definitely higher than 100, 150. So, and when you start seeing it on the dipstick, if it's say anything beyond trace, then you're starting to get significant amount of protein in the urine.
Okay, so now we've checked a patient, we've checked their EGFR, we look at their albumin to see if they have albumin or they don't in the urine. Maybe we checked the cystatin C as well to kind of confirm the EGFR. And now we've established that that person has chronic kidney disease. I know that's kind of from a conventional medicine point of view, that's kind of where we
Mhm.
stop, right? You have stage,
Mhm.
like let's say when they actually care is when they're at stage 3A, but in the meantime there was stage 1 and stage 2 and then stage 3A. So from a conventional medicine point of view, you stop. Let me ask you, first of all, when the albumin is leaking in the urine, why is that a problem?
Well, I mean, the data says that actually albuminuria can be harmful to the tubules, so that is also can be inflammatory to the kidneys themselves.
Okay.
So, you can think of it as a marker. A lot of people just use it as a marker of the active inflammation that's going on in the glomeruli. But also, there's more data that shows that it's also damaging to the tubules and can be associated with faster loss of kidney function. So, this is why we want to try to decrease that as much as possible.
And doesn't the liver decide, okay, we got to make more because it's spitting it out? So it starts revving
Yeah,
that up and revs up
right,
cholesterol
right.
and yeah,
Yeah,
cholesterol and all
exactly.
those things. Right, right.
Yeah, especially if you start getting into the nephrotic range, and when you start getting like above 2200 of albumin in the urine,
Mm.
then the liver start kicking in, and you're increasing your risk of, hyperlipidemia and, coagulopathy and all kind of problems.
Yeah, yeah. So sounds like the kidney's pretty important. Um,
A little bit.
so now I know that you guys will also, or primary care doctors or primary care providers will at some point check a parathyroid hormone. They'd also check. So tell me just more sticking to what a conventional approach is. You're going to look at parathyroid. What else are you going to really look at from a conventional medicine point of view before we get into the functional medicine?
Yeah, I mean, if you're really a good nephrologist, you will make sure obviously the blood pressure, hypertension is one of the things that we want to make sure that is controlled. And,
Mhm.
if you start looking at what's causing the kidney disease, right? It's not enough to know it's chronic kidney disease. You have to know why there's chronic kidney disease. So a
Right.
good nephrologist will do more. Will start looking into, does the patient have diabetes, or if it is diabetes, is it the only cause, or there's something else going on? There are some serologic tests that, kind of the bread and butter. So we look at the complement level, we look at the serum protein electrophoresis, immunofixation, hepatitis. We make sure that we're not missing something that is reversible.
Right. So
And yeah,
let's break that down. So what did you say before serum protein electrophoresis? You said complement, and that's
complement
looking for
level.
what
Yeah.
disease?
So that looking for glomerulonephritis, basically, there are
Okay.
some type of glomerulonephritis or autoimmune kidney diseases that are associated with decreased complement levels, consumption, basically. So you're seeing that there's like C3 or C4. You can do like a whole slew of complement assessment now.
Okay.
But if you have the common one, if you have low C3 or C4, they kind of point you into specific glomerulonephritis or autoimmune kidney diseases.
And protein electrophoresis, like SPEP, UPEP, right? Urine and in
Right,
the
right.
blood. And what are you looking
Mhm.
for there?
We're looking for myeloma or amyloidosis, or bone
Right.
marrow issues that are causing kidney disease. Yeah.
And then what was the third one that you mentioned?
Hepatitis, we check for
Okay.
hepatitis. So we look for, I like to get a comprehensive, hepatitis panel, but at least hepatitis B and C, you check for those, because there are also specific glomerulonephritis that are associated with hepatitis. So like membranous nephropathy,
Okay.
MPGN and stuff like that. So
Do you ever check like an ANA or any of that stuff or
yeah, so that from conventional
yeah.
aspect, it really depends on what we see on the urine analysis. So the urine analysis, we did not mention that. It's kind
Okay.
of the cheapest, easy, one of the things that I do, like make sure I have a UA and urine protein to creatinine ratio, or albumin to creatinine ratio, and the renal panel. So those are minimum. So UA, if you have what you call active sediment, so you have blood in the urine and protein in the urine. Possibly, if your lab did their due diligence and looked at the microscope and saw any, presence of cast or something like that, where the red blood cells are clumping together. So if you start seeing like activity on the UA, which is pretty cheap, then you will start thinking, okay, we're dealing with glomerulonephritis for sure. We really need to focus on expanding that serologic workup. So we do ANA, can do something called ANCA, you can do anti-GBM antibody. You can go like into a whole serologic, panel. Antiphospholipase receptor antibodies now is a new thing. For membranous nephropathies is one of those serologic tests. So we can expand as much as needed based on the findings from the get-go.
Nice. And I think how often do you think nephrologists miss doing these tests?
Like I said, I mean, I don't want to be talking bad things about nephrology because I'm a
Yeah.
nephrologist, to be honest with you.
Yeah, yeah.
And I think, a good nephrologist should not miss those things. So I'm
Do
just
they
saying
do they miss them often?
they may miss them.
Well, because should the primary care practitioner be aware so that just in case it's missed, they're checking it? Because for me, once you start getting into glomerulonephritis and nephrotic syndrome and whatnot, you got to see a kidney doctor. Whereas
Right,
certain
right.
stages of chronic kidney disease, and you know what it is, we're good. But you don't need the kidney doctor. We don't have enough kidney doctors to take care of the massive
Right.
amount of people that you mentioned. But yeah, I do think it's good for us to remember and kind of know these
Yeah.
things. Now, let me ask you, what about imaging from a conventional point of view? What kind of imaging is required if it's required?
I mean, if you think about the conventional way of thinking about kidney disease, you have the pre-renal, the intrinsic, and the post-renal. So you also want to make sure that the patient doesn't have obstruction of some sort. So renal ultrasound is one of the things, and like unless the patient have an obvious kidney disease, most of the time, if there is a low GFR, I will be getting a renal ultrasound. It will give us an idea also how chronic is the disease. If there is a lot of what do we call increased echogenicity, you can see some scarring. And sometimes you'll be surprised and you detect some obstruction of some sort. I asked we're bridging between functional medicine and conventional medicine. So I always ask the radiologist to check for something called post-void residual urine. So the patient will go and urinate, and then they ultrasound the bladder again. So if you don't empty your bladder, then we have a problem too. So so all of that is useful, and also ultrasound is pretty relatively cheap.
Because
So
if you have them go pee and then you check
mhm,
their ultrasound of the bladder again and it's full, you could be having a backup, right?
exactly, yeah,
Okay.
exactly.
And you mentioned something earlier too that I think a lot of patients, so this is for the functional medicine champions and health coaches, a lot of them, they think that the specialist for blood pressure is the cardiologist. And you mentioned blood pressure, and what they don't know is you're actually nephrology and hypertension, right?
That's
You
right.
guys,
Yep.
kidney is actually, you guys, I don't know if you won some sort of arm wrestling match with a cardiologist, but somehow you got that in your name. Um,
Yeah, yeah, yeah.
yeah,
Well,
which
there's
which
always
just shows you that.
nephrology and cardiology. There's always
But that just means that's just probably because the kidney does regulate a lot of our blood pressure, right?
true. Yeah,
Yeah, so
exactly,
when it starts
exactly.
hurting, your blood pressure goes up, which makes things
Yeah,
worse. So now
yeah.
let's get into the fun stuff. We had to get through this. We had to get through. Let's
Right, of course. Yeah, yeah.
have we missed anything else from a conventional point of view? Like if they do this, they're like the best, top
I
notch.
think like you got the most of it. I mean, that's what I have conventional medicine clinic too, and that's the bread and butter. So easily, if you do this, you're pretty good, better than a nephrologist. Yeah.
Right. So all of you primary care providers and nephrologists, unless you want Dr. I to judge you, make sure you're doing this. All right, now go and you're being so careful to not. I'm sure there's every field has those people that kind of aren't doing everything they're supposed to. Nobody's perfect. I agree, but I like having fun with it. Why not? All right, so now let's go. We yes, it's we want to diagnose it. We want to make sure we have the right diagnosis. The last thing you want to do is throw probiotics at somebody when they have a disease that needs to be treated, right? So you don't want to
Right,
miss any of
right.
that. But now let's get into what are the more advanced tests that help you find out what's actually happening and what's causing their kidney disease? We can go one by,
Yes,
yeah.
right. So, I mean, I think that it's helpful to think about chronic kidney disease as not one disease, right? So we're dealing with a lot of things that can cause kidney damage. And I like to kind of simplify it into 5 buckets. So we have the cardiometabolic kidney disease, which is, diabetes, hypertension type of thing, which is kind of obviously the most common.
Okay.
And then you have the autoimmune, the glomerulonephritis. That's kind of the second most common. And then you have the cystic and genetic kidney disease. And
And that you'll
then
see on an ultrasound, right? The
and that you
cystic
see on an
planet.
ultrasound, right?
And that's where your
And
kidney's full of cysts. Mhm.
so yeah, that's polycystic kidney disease is the most common genetic kidney disease. And then you have the drug-induced kidney disease, it's a bucket that I put it by itself. And then finally, I think if we add kidney stones as another bucket, because that is also very uh, important thing that I deal with personally, because I have passion to dealing with kidney stones, and it's very painful. All right, so it's very painful, and it causes a lot of problem for the patients. And there's a lot of things that we can do for this patient. So when you're dealing with a cardiometabolic patient, you're looking for similar situation that you deal with, like looking for insulin sensitivity, blood pressure control, and those patients benefit from what we call plant dominant diet, for
So
example.
Dr. I,
Yeah.
let's do this. Since cardio, I would love to bring you back. Let's see after this if you're ready to come back. I'd like to bring you on just to talk about kidney stones because I do think it's
Yeah.
overlooked but since cardiometabolic is the main is most of these people fit in that category,
Mhm.
cardiometabolic. Why don't we just break down that cardiometabolic? How do you evaluate cardiometabolic, which is the most common cause? How do you look at those underlying imbalances that are causing your patient's kidney disease? So let's just do tests and then we'll go into treatment. So from a test point of view, what
Yeah.
tests are you looking at doing?
So we're looking at insulin sensitivity testing. So the HOMA. Um, um, so we look at C-peptide and obviously the A1C.
Mhm.
The So those are the beginning tests that I will do. I
So
also
insulin, C-peptide, and A1C, do you get and you calculate maybe a HOMA IR or
right.
I know Quest has that, they have their own insulin sensitivity test, insulin
Hmm.
resistance score. Do you ever get that
Right.
test?
Yeah. Yeah.
It's like their proprietary formula, but it tells
Well,
you,
that's mostly what we use. Quest is what we use. Yeah.
okay, so then that's looking at the whole sugar and insulin that could be driving, and that's actually causing and driving the kidney disease.
Exactly. Exactly.
Okay, what else are you looking at in that?
And for the blood pressure, we're talking about, I mean, we start talking about measuring plasma renin activity, serum aldosterone level. I often end up doing 24-hour urine collection for methanephrine and aldosterone, cortisol level also. So,
And what are you ruling out there? What are you ruling out?
we're hyperaldosteronism, which is actually very underestimated, to be honest with you. And if there's hypercortisolism. You can use the saliva testing for cortisol too, if you're interested with that. So that can help with managing, looking into the other etiologies of hypertension. So those are the things that I use on
So,
those patients.
so the saliva, so that by the time the 24-hour cortisol is high, the urine, because you do a 24-hour urine, by the
Mhm.
time that's high, that's basically kind of like a Cushing's, right?
Yeah, exactly.
That's high. Now, when we do saliva, though,
We're
it can be
detecting early.
high, and I know some practitioners they've never done a saliva cortisol test. They see it, they freak out, thinking the person has Cushing's, and they don't because it's looking at kind
Yeah,
of like a subclinical. So when if that saliva cortisol is high, do you obviously you don't freak out with that. You have things
right,
that you
right.
can do, right? Um, But then that's something that there's more of a holistic, integrative, functional medicine approach. Whereas Cushing's,
Yeah.
that's you
Or
either have a
more,
tumor or right.
right, right.
Yeah.
You're dealing with a conventional approach. But I mean, when I start going into, I mean, beside the
Mhm.
stress and the sleep cycle and all that stuff, if it start going into the weed with hormones, I don't really do hormones much, so I
Okay.
kind of send them to functional medicine doctors that I deal with,
Okay.
that have passion for it. So I don't deal with the hormone, specifically from functional medicine aspect. So
Right, right. You're figuring out what's going on.
yeah,
You're a nephrologist. You're dealing with the very serious things. And then high cortisol, we'd be more than happy to take your referrals. I'm sure many of the people watching will be happy to take
perfect.
your referrals. And then that way you can say, all right, their cortisol is high. This guy needs to deal with stress management, take care of it. And here's one of my poems, right?
Yeah,
You give them, but be careful which
yeah.
poem you give them. You don't want to get them
Right, right,
depressed
right,
either.
right.
It'll
No,
go
yeah,
higher.
we'll be the happy ones.
Okay. So now that now they have you've done not only a regular workup, you've done a more advanced workup. And now you know you're looking more and you're seeing what's causing this kidney disease. What is it? The kidney, a lot of people don't know, but the kidney also regulates your blood cells, right? So
Right.
you have erythropoietin that's made
Yeah.
in it that tells the bone marrow to make red blood cells so they can start to get
Mhm.
anemic. Um, I know that a lot of times, I know that it helps activate vitamin D, right?
Mhm.
So in order for vitamin D to be fully activated, you need the kidney, you need the liver, and then you need the kidneys to work well.
Exactly.
So are you checking vitamin D levels and are you giving them vitamin D?
So yes, and that is definitely. I mean, first of all, I'll check vitamin D level on my patient at least twice a year,
Okay.
um, because I mean the parathyroid hormone. You mentioned the parathyroid
Yeah.
hormone earlier. Like this is what conventional medicine doctors and nephrologists do, and I think there is nobody even know. Like if you read the literature, you don't know what parathyroid hormone should be in a CKD patient. So I try to target vitamin D level, and like how conventional medicine they say, oh, 30 is pretty good. I like to go to 50 to 60 at least,
Okay.
and make sure that the patient is in that range. Um, I mean, one of the things that I also do, I mean, like on patient is nutritional evaluation, and with a dietitian, from the get-go, they have to be seen by a dietitian, like not the conventional medicine, when we have to, they only allow you to see the patient, the dietitian see the patient when they are CKD stage 4. So patient in general should have from the get-go dietitian evaluation.
Right.
I don't know if we're allowed to mention commercial names, but
Yeah.
there are
If you're,
some labs
yeah.
that we use that the NutriVal, for example,
Yes.
is something that it's a go-to, and it gives you big, amazing ideas about what's going on with the patient from nutrition standpoint, and help you with personalize their diet and
So do
approach.
you
Yeah,
feel like, so you mentioned the Nutravel and you don't, I mean, I think as long as we disclose our connections, do you own the company that makes Nutravel?
I have no
No?
no association with the
Unfortunately, it
company.
would have
Yeah,
been nice if yeah.
you know,
The
it's a good test though.
yes, so now Nutravel is checking blood and urine, right?
Right, right.
And it's looking at nutrition kind of from different angles because it's not
Hmm.
you can't always just check the blood work to see the
Yeah.
levels. Now Nutravel, since you're looking at urine and blood, if you have kidney disease and if it's off, does that affect the Nutravel result?
That is something I actually don't know, to be honest with you. It is possible that
Yeah.
some stuff that can be affected, because the kidneys are not, clear in it. So it's a possibility that some of the stuff could be looking normal, but they're not actually normal. And there's a functional deficiency or what have you. And in the urine, also it could be affected. The organic acid test could be affected by the CKD. So yeah,
Okay.
so that's true.
So back to the you said you like doing a Nutravel to kind of see what kind of some of their maybe nutritional imbalances and you like to to work on that. Now, there's research coming out on the gut microbiome and gut and kidney disease. Are you doing it? Are you looking at any of that?
Absolutely, absolutely. So, like I mentioned, all these buckets that for kidney disease, all of them, what you're managing, whether you're managing cardiometabolic or, genetic kidney disease or cystic, you have to look at the gut and you have to look at the mitochondria or support the mitochondria. So that's the two overarching issues that are happening with CKD. You have mitochondrial imbalance, you have oxidative stress going on and microinflammation, and you also have gut, what I call gut kidney connection. There's a entity that I call it the uremic dysbiosis cycle.
Okay.
So you have dysbiosis where the imbalanced microbiome in the gut, and that causes the increased permeability. You have inflammatory uremic toxins going into the circulation, causing inflammation,
And
worsening
let's talk about
CKD.
uremic toxins. So uremic
Yeah,
toxins, basically, those are the toxins that go up that the kidney is supposed to deal with. So those
right.
start to
And
go
then,
up.
but they're also produced by the gut bacteria. So they're produced by the gut bacteria. We absorb them. The kidneys are not able to get rid of them, so they circle. The circulation at a higher level. They cause more damage to the kidneys by causing inflammation, cardiac inflammation, cardiovascular inflammation. So they worsen the kidney disease, and that causes more dysbiosis. So you end up in this vicious cycle.
Right. And so do you ever give probiotics? Because I think there's certain strains of probiotics they've looked at.
Yeah, I mean, so my approach with my dietitian on the gut health does not only just throw probiotics. So basically, you have to do a comprehensive gut restoration protocol. So you look at the repair, rebalance, re-inoculate. The 5R protocol,
Right.
kind of having repair, remove, replace, repair,
Rebalance,
re-inoculate, and
reinoculate, right.
rebalance. Yeah.
Reinoculate, rebalance. Yep, yep.
Yeah. So we do all the steps to make sure that the patient is getting the gut repair that they need comprehensively, not just throwing prebiotic or probiotic or postbiotics. So it has to be comprehensive.
So the one of the things that I see happen often is that you have somebody that wants to get healthy and they're told eat 100 to 120 grams of protein a day. And then conventional docs tell them, oh, no, no, you're going to mess your kidneys up. I mean, not realizing that they're eating 120 or more a day, plus they're eating carbs, plus
Mm.
they're eating all the other things. But
Right,
that being
right.
said, so what point? So protein, why is high amounts of protein, why is that going to be something that you want that people are cautious of if you have kidney disease? What is it doing? And does it matter if it's
Yeah.
plant or animal?
Yeah, so there's a lot of data actually on the protein right now, and I think when you start getting into the we can talk about more specific, but the protein in general can cause vasodilation in the kidney level. So you have increased hyperfiltration. You're familiar? Hyperfiltration, one of the early injuries that happen with the kidneys. So the kidneys are working like you have your kidneys on steroids, working extra um, to filter all that protein. So you have increased pressure on the kidneys. One of the things, like the ACE inhibitors, the ARBs, these are the medication that are used conventionally to decrease the pressure on the kidneys. The protein is causing the opposite, and so that will cause faster progression of kidney disease. In addition to that, you have a higher dietary acid load from the protein, especially animal protein, and that will cause the kidneys also to increase the capacity to get rid of that acidity. That we're talking about blood acidity, not to
Right.
confuse with the stomach acidity. So that high dietary acid load also causes inflammation at the kidney level, and these are well documented. So probably animal protein worse than plant-based protein in general, and the alkalinity can play a factor here. So alkaline the veggie based protein may be more alkaline than an animal source.
Do
So
you
they recommended in
yeah.
general, plain, when I see a patient, even in a conventional clinic, they have to cut down on their animal protein intake.
So what if they flipped it and what if they had mainly plant protein? Is there a amount of grams that, because here's the thing, on the other side, when we have people with metabolic syndrome, with diabetes, we want to up their protein to carb
Mhm.
ratio so that the body goes into muscle storage instead of going into fat storage if carbs
Sure.
are higher than protein. So is there a, so you try to shift them. Is there a certain stage of kidney disease where you start to focus, or from the beginning? Stage one, stage two, stage three. When do you
From the
start
beginning,
focusing?
I would say early on, the early for the kidneys, the better, to be honest with you. So the early on, we would like to have them follow a plant-dominant diet.
Mhm.
And I'm not saying they don't have to be vegetarian or vegan, they, as long as they cut down on their protein intake. And we're talking about, I mean, I can tell you by the gram per kilogram. So we're talking about 0.8 gram per kilogram per day. That is, the reasonable restrictions. When you start going into advanced kidney disease, if you want to kind of delay them from going on dialysis or something like that, you go more stricter. There
Okay.
are very strict diets, like protein diet, but that can probably cause more problems, especially for elderly population. You end up having sarcopenia, and patient will die from other problems before they have kidney disease or
So
kidney failure.
so let's hear that for you. You said zero point 0.8 grams per kilogram per day. Now, if somebody weighs maybe in the four or five hundreds, of course you're not gonna continue that out, right?
Yeah, yeah,
But
yeah,
let's say the typical, let's say the 70 kilogram, what's 70 kilogram in pounds? 160-ish. My math,
yeah.
oh my God, on the camera. But 150, 60-ish pounds would be, so if they're 70 kilograms, seven times, that's about what, seven times eight is
We're
56,
talking about 60
60.
grams of protein. Yeah, will be reasonable.
Now, at what stage? Because we like getting people higher. We like getting people up to the at
I
least
mean, stage
80
three definitely need to be restricted for sure.
going lower. But so how much leeway does plant-based give you? Because for me, looking at the other parts of the body, as an internist, I know one of the issues that women will have because they don't weigh as much,
Mm,
when you're looking at your food as there's a percentage of protein, a percentage of fat, and a percentage of carbohydrates, the macronutrients, when if they decrease the amount that they're eating in order to maybe lose fat, when they do that, if they stay those same percentages, then what happens is we worry about them getting protein deficient because you need
mm,
proteins for your amino acids, and those amino acids we need to make neurotransmitters, your serotonin, your dopamine, your happy
yeah.
neurotransmitters. So you need protein. So I get a little worried when people start going under 80 grams of protein a day. But then
Mhm.
again, I like them 100, 120. Now, this is not people with kidney disease.
Yeah.
How high do you believe you can go if you're using, because you see the challenge, right? You protein is going to help them in other ways.
Of
You're either
course.
using
Yeah.
protein, fat, or carbs for macronutrients. So how high could they go if it's more plant-based, like rice pea protein, or so if they're
Mhm.
supplementing with that with plant-based protein, having a little bit of animal protein? How high would you allow them to
Yeah.
go?
Well, I mean, so they can, well, number one, I mean, follow up on this. Patients should also have a follow-up NutriVal test
Yeah.
in a year. So, every year at least we check them to make sure that they're not being malnourished because of the diet that we're supposed to have personalized for them.
Yes.
The other aspect of it is that if the patient does not want to restrict their animal protein, or there are some data that if you liberate the protein intake, you have to also have extra servings of veggies to kind of fruit
Balance
and
it.
veggies to balance out. And we're talking about adding like 7 to 8 other servings of fruit and veggies every day to the standard American diet. So that if you want to do that, that's fine. Making sure that the patient
The
is also not going to
standard
be
American diet probably has one.
yeah, right.
So they just need 7 more,
Yeah.
which is what we want anyway.
Seven, like we're talking about 10
Yeah.
overall, at least 9 to 10,
Yeah.
servings.
So 8
So
servings, 7 to 8 servings of veggies, 2 servings of fruits, not too high in the sugar because it can
right,
cause it.
low sugar fruit, yeah.
So that brings us, and it helps alkalize the urine a little and antioxidants.
Right, exactly.
Do you have your patients check their urine dipstick to see the acid level?
No, because it's not accurate.
Okay.
So the urine pH on the urine analysis is not really that accurate. So if you want to do accurate testing, you're going to have to do a 24-hour urine collection and has to be properly stored and so on. So I wouldn't really depend on the urine pH.
Is it not
on your urine.
accurate because your pH goes up and down? Is that why it's
Yeah,
not
there's a
accurate?
lot of factors, and
Yeah.
the testing is not accurate. Yeah.
It would be interesting to kind of look. I think I'm going to do that, to look and see, is there a way they could do the urine dip like twice a day or 3 times or after meal, or just to kind of see.
Yeah.
Interesting, because it's always nice for them to have something they can work on.
That
So
would be a good research to publish together. Yeah.
let's do it. Let's do it. So
Yeah.
so as soon as we hang up this, we'll get on a phone. So actually we could stay on this thing and just unrecord it. So what we could.
Perfect.
So now you have somebody, they're starting to get into kidney disease. You're telling them, start cutting out animal. You don't have to be completely vegetarian, but cut out animal. You're going to cut out the, you're going to add plant-based protein, right? And which kind of brings me to one of the reasons we need protein is because of amino acids. So do you ever give them isolated amino acids instead of giving them the protein that has it all together? Will you give them amino acids? Because tyrosine is going to become L-dopa, dopamine, and norepinephrine, and then tryptophan can end up becoming 5-HTP, which then can become serotonin, and so on and so forth. So do you ever say, all right, we're cutting your protein, but we don't want you to be amino acid deficient. Let's give you these isolated amino acids. Do you do that?
So there are things called keto analogs. I don't know if you're familiar with them. So
that
these
was
are
actually one of
kind
my
of
questions. Yes, the keto analogs.
Skeletons that kind of end up forming into amino acids in the body by the metabolism. So those are good support for those patients to maintain good amino acid balance and maintain adequate nutrition. So especially for those who are on very strict protein diet, definitely you have to give them the keto analogs.
And a keto analog it has ketone and it has amino acids together. Is that how it works, or is it just?
It's a skeleton of keto acid that is when you take it, it will bind with some carbs in the body and form the amino acid that are become non-essential, like your essential amino acid. You can form them inside your body, by the keto analogs.
What about sugar? What about carbohydrates?
Yeah, I mean, you want to minimize the carbs as much as possible. I mean, the problem is like we're leaning to ketogenic diet, but not completely. And honestly, you have to, like a lot of people when they when they hear about ketogenic diet from a nephrologist, they freak out. But it has to be a modified ketogenic diet, and also a dietitian has to really formulate that, because we need to make sure that the patient is eating healthy fat, but not a lot of protein also, and maintaining good caloric balance. So a lot of veggies, a lot of low sugar fruit, and limiting the carbs in general. That is definitely we're talking about the cardiometabolic kidney diseases. Now, if you switch to genetic kidney disease for a minute, for the polycystic kidney disease, those patients should go on a ketogenic diet. There's a lot of data that now support that those cysts are dependent on glucose for their energy. So the more there's, carbs in diet, the more these cysts are going to get bigger and bigger and faster. So when we talk about
Wow.
our gene not being our destiny, so you can modify polycystic kidney disease, that is the genetic kidney disease, by diet. And there's data coming, right after another. So the approach for the genetic kidney disease is a little bit different. So you have to do modified ketogenic diet, a lot of water, because also water can, suppress the ADH and also slow down the progression of kidney disease.
So Dr. I, I think this is pretty mind-blowing. How many people get diagnosed with polycystic kidney disease and are just told, we watch it. They're not told anything, right?
Yep.
Like what do they do? Just watch it?
Yeah, that's well, come to the nephrologist, will tell you, oh, your kidney's stable or not stable, whatever.
Yeah.
Yeah,
Based
I
on
mean
just
that's
waiting for it. But if they
mhm.
feed on, that's pretty profound. If they feed on sugar, you cut sugar so that the cysts don't grow and then go more on a ketogenic
Yep.
food plan. All right. So what about, I know a lot of times we check phosphorus levels and sometimes their potassium starts to go up at different stages. So what about the phosphorus? What's the phosphorus piece?
So the phosphorus is, I hate phosphorus. So phosphorus is really bad. I mean, I know a lot of people like it, but for kidney disease, the problem that we're dealing with, there's so much phosphorus in our food right now, and they're adding it as, additive to a lot of things. So when you go to ultra processed food, you're getting mind-blowing amount of phosphorus, whether it's for coloring, for preservation, or what have you. So there's two types of phosphorus in my mind. There's the organic phosphorus that comes in the food, like bound to protein or what have you. We don't absorb most of the phosphorus that comes in plant sources because it's bound to things that we don't digest. And we have the animal-based phosphorus that's organic also, and we probably absorb 60% of that. But the ultra-processed phosphorus, we get 100% of that. The one that is in colas and diet colas and processed food. So this is where we want, one of the reasons why we want to stay from ultra processed food, because it's like super inflammatory.
So is it
But you have,
phosphate? Is it phosphate, the
it's
ultra
phosphate, yeah.
Yeah.
But well,
Okay.
phosphate. I mean, we use the word phosphorus, but we're talking about is phosphate actually,
Yeah. Yeah.
and that can cause a lot of problems because then you have activation of hormones we don't measure. There's something called FGF23 that is like a fibrotic hormone that is produced by the bones when there's high phosphorus intake. You can have normal phosphorus level, but you have high phosphorus intake, and the kidneys are working extra hard to get rid of that phosphorus, and that FGF23 is being produced at a higher level, causing cardiovascular inflammation and vascular inflammation, and can cause faster progression of kidney disease. So we do want to, kind of work on that phosphorus piece.
So
Phosphate.
there's a lot of videos coming out from these nutritionists that are saying, stop listening to influencers, social media people. Diet soda is an excellent hack. It's like one of the best things you can do. It's easy, and they'll have all these sodas in front of them. So how's that make you feel?
Horrible.
You're like, they're kidneys. I know
Oh
it.
yeah. Oh
You
my
can't. Do you
God.
check?
And all these bad sugars. Oh my God.
Do you check phosphate? Does it show up in the blood when you check a phos level?
Oh yeah. I mean, if you, I mean, I don't use comp panel or BMP. I use renal panel. The renal
Yeah.
panel has phosphorus, has serum albumin into it, and calcium. So the phosphorus level, I honestly, it's so amazing. Like I see people with like early kidney disease have high phosphorus in their blood. It's so mind-boggling. I mean, I don't know what we're eating, but it's loaded with phosphorus for
And
sure.
phosphorus, so that when you look at phosphorus, you don't know if it's the bad kind or the kind you need.
No, yeah, yeah. I
It
mean,
tells, it
you're
looks at
talking.
both.
It's already
Okay.
in the blood. Yeah. Yeah.
Yeah, because I remember on the internal medicine rounds on the floors, some people are phosphorus deficient, so we would give them
Right.
phosphorus.
Right. Yeah. Yeah.
But
I mean, obviously, we're not going to deprive someone if they need
yeah,
phosphorus, but
yeah, but I
certainly
wonder,
most of the patients are having high phosphorus intake.
I wonder if that's something that we could break up to see how much is this artificial stuff and how much of it is the phosphorus that we really need. Because if a regular phosphorus level is just looking at both what you're finding in the sodas, but also then yeah, that would be
Yeah, I
interesting.
don't. Yeah,
Yeah.
yeah, that would be. I mean, I don't know after you metabolize it if you're able to, short of like giving some isotope or something to follow, which where it came from, where it ended up being. I don't know that there's an easy way to do it.
Now, we know that supplements do not cure disease. We know that we're looking at imbalances and we're trying to help heal the underlying imbalances. From that aspect, what are some go-to supplements that you just think are the best when it comes to kidney disease?
Yeah, I mean, like I said, I mean, I like to not say we go to or what have you, because
Yeah.
like you want to really go after what you're doing, based on whether it's cardiometabolic or autoimmune or what have you. So
Yeah.
I hate. I mean, I'm sorry, I don't. I want to
No, no,
push
it's for
back on this
Instagram.
question because
Listen, Instagram, you have to say game changer, go
okay,
to,
all right,
or people don't pay
okay.
attention. So
So
thank
go
you for
to, because
clarifying.
I want to make sure, because I mean I see a lot of functional medicine practitioner talking about the one thing that is
Yeah.
going to reverse everything. There's no one thing. There's a million things you have to do to personalize it for that patient.
Right,
Because
right, right,
if I mean, otherwise we will not be practicing true functional medicine, right?
right.
But
Yes.
but the go-to, I mean, definitely, I want to make sure that the patient is on CoQ10.
Okay.
They do need their mitochondrial support. I
Yeah.
do make sure that they're on B complex, depending on whether their methylation status, whether it's methylated B complex or B complex in general. We
Based
do
on
want to support.
homocysteine, you check homocysteine
Yes,
levels?
yes,
Okay.
right. And then we have, we're talking about also the, mitochondrial support. So some patients will need glutathione support too. So N-acetylcysteine, or even liposomal glutathione if they can afford it.
Okay. So you
Or,
really
so
like
those
the
are the
antioxidants.
top three. Yeah. Oh, yeah. Absolutely. It's a high. I mean, it's a high oxidative stress situation
Yeah.
with CKD, and there's microinflammation going on all over the body.
All right. Well, thank you. I think that was a great interview, and now it is time to spill those functional medicine organic beans. And now we're going on the clinical experience share, where we're going to go. This is to the practitioner side of things that is not on the public podcast, but we're going to go over what ChatGPT is not allowed or is not going to be able to tell us. So thank you very much. To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive, look at personal experiences and real world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show. Welcome back, everybody. We are now at one of the parts that I love, and that is making an impact. If you look at the functional medicine practitioner as a tree, the tree is producing fruit, and fruits have seeds, and those seeds can be planted to make more fruit. That being said, functional medicine, from a functional medicine practitioners, we strongly believe that they should be giving back and they should be helping and make the world a better place. And also kind of the seeds are really that legacy. So with that, starting with this section, Dr. I, before we get deep into making an impact, I want to ask you, what are you excited about right now?
I'm excited about the fall of the Syrian regime. So yes, I'm excited about my homeland, hopefully, moving into the 21st century eventually, but after years of, I'm hearing horror stories, so I'm hoping that we'll improve the country for sure. So I'm excited about that.
And hopefully we'll all send positive energy to the Syrian people.
Thank you.
Just to bring that. Now, are you excited? What about books? What are you excited? What projects are you working on that you're pretty excited?
Yeah. Well, I'm really the other thing, but I'm excited. This is like the 2025 project. There's the integrative nephrology textbook. Hopefully this will, end up seeing the light of the day. But and you got to send your contribution anyway. So, but hopefully that will be published by the end of the year.
Yeah.
If I can get that going, and hopefully this will be the first iteration of that, that will be hopefully my legacy, that I have contributed to changing the way we can manage kidney disease, and start the process that we should change the system, because the system is broken.
Right.
So I'm really excited about that.
Thank you for inviting me to be a contributor and one of the authors on the book, but also thank you for calling me out in public, because now I gotta get my act together. So what are some impactful ways that practitioners can contribute to their communities?
So there's a lot of ways. I mean, you also, there's free clinics you can join in every community. Donating, of course, you can, there's a lot of charities that are available. And like here, we're in Vancouver, Washington, there's a Clark County Food Bank. You can volunteer there. You can donate to them. I volunteered in medical missions. So that's another thing you can do. You get exposed to different cultures, different, practices and in the world. So these are available, and it's you actually you have to invest into it, because those are a lot of time. You have to pay your own fees and whatever you travel. But what you get back is unbelievable. The amount of growth and like at the spiritual level from these medical missions is amazing. It's not only that you're treating people, you're treating yourself. So I highly recommend that people go on medical missions to, a different part of the world and do different things.
So if somebody wanted to start, how would they do that?
Well, I mean, there are a lot of organizations. So I can say if you're into nephrology, there's the Bridge of Life is an organization that can, you can go on missions with them to various places in Africa and Southern America, do a lot of screening for kidney disease and hypertension. I went with them to Uganda and Jordan. There's also the Syrian American Medical Society, which send missions to the areas where there are Syrian refugees, and also to other areas in Greece and Bangladesh. Of course, there's the Médecins Sans Frontières, the Doctors Without Borders. So all of that available for you if you want to join and help.
Nice. So more at a financial level now. So I know I like donating to the Institute for Functional Medicine. I like donating to the environmental work group. What do you think, what organizations do you feel like we really want to be donating to help the world be a more integrative, functional medicine, healthier type of world?
I think you mentioned environmental working group is one of my favorite organization there. there's a lot of stuff sometimes gets tricky with them, but Institute of Functional Medicine, probably I should do that, more of that, and renew my membership for sure. I don't really know what other organization, to be honest with you. So I'm glad you mentioned those. I don't know if you have any other tips, because I don't. Yeah.
No, listen, Institute for Functional Medicine, if you're watching, I want my commission check. I just got his membership back. No, I'm just kidding. I get no commission. Well, thank you very much for taking the time with us. How do patients stay connected? How do practitioners stay connected with you? Website, social media?
So on Instagram, we're at integrative kidney. On Facebook, we're on at, can you hear me? At Integrative Kidney Institute on Facebook. I do not answer social media anything. So no, don't ask me anything on social media regarding specific patients.
No IM, no DMs, no direct messages. Nice. And then you have a website, don't you have a website that is that has all kinds of information, because people are going to be out there and they want to help others that have kidney disease and they're getting no guidance. What's your website?
There's a lot of information on our website, www.inkidney.com. Our blogs are like full of information. A lot of the stuff we mentioned to you. I don't get anything, like I'm trying to put a lot of information out there to help people. So yes, please read. And we have also a practitioner directory. So if anybody who is practicing functional medicine and nephrology, whether you're a dietitian or a nephrologist or what have you, if you want to be listed there, please email me.
Dr. I, one of the probably the most valuable commodity we have is our time, and you have been so generous with your time. So thank you so much for sharing your wisdom and experience. And I am looking forward to reading your poetry. My Arabic isn't that great, so I'll probably have to ask ChatGPT about the Arabic part. Just give it to me and I'll put it through and have a discussion with her or him. That being said, though, well, thank you so much sincerely for coming.
Of course.
Thank you.
Thank you for having me. I appreciate it.
Absolutely. Hey everyone, I'm Dr. Yusuf El-Yaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please subscribe. Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.